4, 3, 2, 1. We are live now.
A very good evening, ladies and gentlemen.
Good evening, everybody, and welcome to this international Tête program by Pulse Pharma, makers of Deksel and Kneeflex. And to introduce the faculty and the topic, I'd like to invite Dr. Harsh. Over to you, Dr. Harsh.
Thank you so much, Ashok. A very good evening, ladies and gentlemen. This is Dr. Harsh Chaturvedi of Pulse Pharmaceuticals. I represent medical affairs and the clinical research of my organization. And I welcome you on behalf of my organization to this very exciting evening, a very exciting topic, where we are going to be learning about certain new ingredients which have emerged, and these ingredients are capable of bringing about a shift, a paradigm shift in the treatment of osteoarthritis. We know that knee osteoarthritis is probably the most common type of arthritis which is diagnosed, and its prevalence continues to increase with the increasing life expectancy, with the rise in obesity, and with not factoring these kinds of age into the aspect. The incidence, I'm told, of symptomatic knee osteoarthritis is roughly 240 cases per 1 lakh patients per year. There is drug treatment, which is progressively becoming mainstay, and all sorts of drugs we have, starting with nutritional supplements, paracetamol, and a number of NSAIDs, corticosteroids, intra-articular modalities, and eventually the surgical issues. We understand very well that the choice of a particular treatment depends on physicians' preferences, patients' acceptability also, and of course, the cost of therapy. So today, we are here to look at and understand, as I said earlier, about a multimodal approach which is being put forward by the eminent speakers who we have with us. Before I introduce the speakers and go on to talk about them, the formulation which we have marketed under the brand name of Kneeflex is the focus of the program, and it's a combination of proprietary ingredients like Collavant N2, Mobilee, Flupin, and Curculife. So before we start the program, I'm taking the liberty of introducing the speakers. I'll be sharing my slides on as I mentioned earlier, this program is entitled Multimodal Action in Managing Osteoarthritis, its importance and the outcomes. To talk to us about the clinical usage, place, and therapy of this combination, we'd like to call it Kneeflex. We have Dr. Niranjan Rathod of Rathod Orthopaedic Hospital, Mobilee, Mumbai, India. Dr. Rathod is a graduate and a postgraduate of Shed GS Medical College and KM Hospital, Bombay. He has almost 4 decades of experience. He has been relieving the populace of pain and improving their mobility. He has organized WIROC 1996 and several implant updates. He is a former vice president of Bombay Orthopedic Society. He is a former chairman of Indian Orthopaedic Association Implants Committee. He is a member of Indian Orthopaedic Association, Bombay Orthopedic Society, Maharashtra Medical Association, and Gujarat Medical Association. With these words, I welcome Dr. Niranjan Rathod to this forum, where he'll be sharing his clinical experience with the use of Kneeflex. We also have the pleasure in having Costa, Larrion, Project Manager R&D, Human and Animal Health, Bioberica, Spain. Ms. Costa specializes in genetics and genomics. Her research interest includes joint and metabolic health. She has been a speaker at multiple forums and to the diverse audience across the globe. And she has published some work on tendinopathies and obesity-related cardiovascular risk. I welcome Ester Costa also to this forum, and we'll be listening to her a bit later. Before that, I would also take this opportunity to introduce my organization, Pulse Pharmaceuticals, which is a patient-centric, innovation-driven, integrated pharmaceutical company with inclusive growth models. When I say patient-centric, we love to hear from the patients what are their expectations and where they experience limitations with various drug formulations. And after learning of those, we try to improvise and innovate on those things. We have been doing this for past 25 years with an active presence across the country and also in the emerging markets. Now we have also started making foray in the European Union, and we are also poised to make our submissions to the US FDA. We have a world-class R&D and manufacturing infrastructure. This has been spread basically over the 3 states of Telangana, Andhra, as well as Uttarakhand. We have our R&D manned by about 150 scientists who are devoted to development of nanopharmaceuticals, the super generic formulations, also the raw material or API as we like to call it. We have strong leadership and operational teams across all business functions. We have in all about 7 business divisions which cater to the needs of orthopedics, peds, gynecology, general medicine, and we also have catered to the public health through our generic business. We are, as I mentioned earlier, leading in the space of nanopharmaceuticals and drug delivery research. Our foremost of the brands is Deksel. I'm sure many of you are aware of it. You have used it in your practice. The biggest advantage of using such a formulation is it's not dependent on absorption in the presence of fats. It can be given irrespective of that, and it has a predictable bioavailability. We also have a strong presence in medical nutrition through Pulse NutriSciences, where we develop various protein formulations for taking care of patients with CKD, cancer nutrition, and protein energy malnutrition. And now we are foraying into immunocell therapeutics by developing the novel CAR technologies, which are the recombinant DNA technology. For this, we are associated with Center for Cellular and Molecular Biology, which is a CSIR setup at Hyderabad. Ladies and gentlemen, we believe in creating customer value through high quality differentiated products and services by using advanced technologies. That is our business philosophy. And with these words, I thank you for listening to me. I hand it over to Esther to start her presentation as an ingredient specialist on the various proprietary ingredients which have gone into formulation Kneeflex. It is over to you, Esther.
So thank you very much. So as he previously mentioned, I think that you can see my screen now, right?
Yeah, you are visible. Your screen's there.
Perfect. So I want to start speaking about Collavant. Collavant is one of the main ingredients of Kneeflex. So it's the one in this multimodal approach targeting specifically cartilage preservation. But what is Collavant? Collavant is a natural ingredient, supplying native type 2 collagen. It's extracted from chicken sternum, that here in the middle, and it's obtained through a strictly controlled manufacturing process that ensures that this native type 2 collagen maintain its characteristic triple helix structure and have available the specific epitopes of the native protein. We will speak a bit more about it later on, because I know you have a broad experience in patient treatment, but maybe your studies in molecular biology are a bit forgotten by the day-to-day life. So I'm getting a bit more into depth afterwards. But thanks to its native form, to its shape, this Collavant allows to work through this immune-mediated mechanism of action. So here, this native type 2 collagen is developed by BioIberica. So we are located in Spain, in Barcelona. It's the original form of collagen as it can be found in tissues. And it works through this specific mechanism of action called oral tolerance. And what it helps is to preserve cartilage through a suppressing immune-mediated mechanism of action. And its efficacy has not only been clinically confirmed in clinical trials, but we have also measured cartilage biomarker analysis to align with it. So it was not only reduction in pain and improvement in function, but also these biomarkers demonstrated it. But what is native collagen? Because let's go back a bit to the basic structures of physiology and molecular biology. So we have the full collagen fiber, that it's full of smaller collagen fibrils. And these smaller fibrils are formed by collagen molecules, this triple helix. And the triple helix is formed by the alpha and beta chain. And that, of course, in the end of the day, derives from the amino acid chain. And native collagen precisely is this triple helix molecule that we were mentioning before, that can be found in several tissues, especially connective ones. So in this immune modulation pathway, so here, for example, we have a drawing, a representation of a joint affected with osteoarthritis. We normally have an initial cartilage damage. It could be caused by several ways. It could be an acute injury or wear and tear or a bad movement or whatever. This initial damage, it leads to formation of cartilage fragments. Then, so this collagen is exposed to the immune system. And of course, the immune system, when it senses something new it may be bad. So it doesn't know if it's good or bad, if it's attacking or harming the body. So the immune system, it attacks the cartilage as this new structure is potentially harmful. And therefore it leads to more damage and more disease progression. Here we can see it in a graphical representation that we have this initial degradation. Then we have these molecules that are left out and that trigger this immune response. And then it leads to more inflammation, and inflammation triggers to more degradation, what leads to more fragments, what leads to more inflammation. So we enter in this kind of cycle of destruction cycle that we want to stop. But what is oral tolerance? Because it's a very nice word, it sounds beautifully, but it's not. It's a well-studied mechanism of action, but it's not one of the most broader known. So in this oral tolerance, low doses of native collagen are administered orally. This regular administration makes the body recognize this native collagen as non-harmful. It's actually one of the mechanisms of the body for not attacking your food or your microbiota, that really your gut needs to learn to differentiate what is potentially harmful and what is safe. And this then stops the immune system attack on the cartilage and protecting this cartilage structure. So this mechanism of action, so to wrap up and to see it more graphically, this orally administered collagen reaches the Peyer's patches in the gut that are these immune surveillance nodules that are responsible from gut differentiation of what is harmful and what's not. They release inhibitory cytokines like interleukin-10, anti-GF-beta. And these anti-inflammatory molecules and these immune cells, these protective immune cells, are the ones going to the joint and turning off this immune response on endogenous collagen type 2. So it's not the collagen molecule that is absorbed and travels to the joint. It's the consequence of this interaction of the collagen molecule with the Peyer patch that travels to the joint and protects it there. So here we're offering cartilage protection, and with this cartilage protection, we will also see that like reduced inflammation overall. But there are a lot of collagens in the market and collagen products, and it may be confusing sometimes because are all the collagen products in the market the same? Are they different? Why do ones tell me that I need to take 10 grams per day and another one just 40? So here I wanted to share with you this image differentiating this native collagen from the hydrolyzed collagen that is also quite popular in the market. And so, and to help us understand why does it need so different dosages and mechanism of action, and what's the real difference between them. So the first one is the molecule. With native collagen, we have the full molecule, the native form, this triple helix that we were mentioning before. But with hydrolyzed collagen, we have this original molecule that was broken down into small peptides or even the amino acids. And therefore it has a different mechanism of action, different dosage, different everything. The types of collagen, they are also different. For native collagen, as we work through this immune-mediated mechanism of action that we were mentioning before, we need it to be specific. We need to have this type 2, because it has these epitopes that are the three-dimensional shapes that the payer's patches will later on recognize as potentially harmful or not. So if you use other types of native collagen that's not type 2, the shapes will be different and the immune system won't be able to recognize them as safe. But in hydrolyzed collagen, as we already broke down the molecule, this three-dimensional shape was already lost. And we are just bringing some amino acids to the body. So really it doesn't matter what kind of product did this collagen come from. It was type 1, type 2, type 3. It really doesn't matter. As we were mentioning, native collagen is not absorbed. It's not necessary because it's recognized from the previous patches. But with hydrolyzed collagen, it needs to be absorbed because their function is anabolic function. So the hydrolyzed collagen is absorbed and then distributed to the tissues, and then it works as building blocks for new collagen synthesis. While with native collagen, what we are trying is to stop this collagen degradation, to go to a natural balance of collagen degradation and synthesis, and not in this unnatural state of excessive degradation. And as their mechanism of actions are so different, really the dosages that you need for efficacy are totally different. With native collagen, you just need 40 milligrams per day. But with hydrolyzed collagen, the normal recommendation, the standard one, is around 10 grams per day. What really can cause a burden in your patients, because with these 10 grams per day, the formulations available are normally sachets or powders. And normally they are not super tasty. Patients get tired of taking them because there are not many options out there. And therefore they don't take them. With just 40 milligrams per day, you can fit it in a capsule, combine it with other ingredients that have also amazing results. And then you can move forward to an easier compliance with the treatment from your patients. Oh, okay. So, okay, this basic story, the mechanism of action was beautifully explained, but it's very interesting. But let's go to the real science we have with Collavant. We'd like to start with the newest study that we got published. It was an animal model. And as you can see, there are many treatments in the market that contain many kinds of different supplements, but does adding Collavant add a difference to your patient at the end of the day? Here we wanted to solve this question because we used a rabbit model of osteoarthritis. Then we had control rabbits that were induced the disease but were untreated. We had ones with an already comprehensive formulation that was chondroitin, glucosamine, and hyaluronic acid. And finally, we have a third group that was this combination plus Collavant. And we wanted to see if to an already existing and powerful combination, adding Collavant would add further benefits. And here we assessed macroscopic evaluation. So we actually looked at the tissues. We also measured the bone, the synovial capsule, and also the tibial plateau images. And what we saw is that really adding collagen, it does provide an additional benefit. Here you have the photos of the cartilage. Here you can see group 0, that was the untreated one. The cartilage looks much more unhealthier, much more reddish than, for example, in group 1 that was treated with the first formulation. But then group 2 that had added Collavant, it provides even better results. And this scoring and histologically also were further improved always in the Collavant group. So in the cartilage and synovial membrane evaluation, and also the MRI assessment, we could see that Collavant and 2 showed better results than the untreated controls and closer to the healthy ones. And we compared to a healthy ones, comparing the other knee on of the rabbit, in which our osteoarthritis was not. So it was not an inter-individual difference. It could actually be compared 1-to-1 in the same individuals. So it really is a very robust results showing that, yes, adding so giving your patients a product like Kneeflex that includes Collavant N2 is far better than giving them other products that don't include this Collavant N2 option. We also, of course, did clinical trials, that is, we are coming here to treat patients, not rabbits. We had a randomized control trial where we included 40 patients with osteoarthritis, Kelvin-Lorentz grades between 2 and 3. The mean age was the mean age for these conditions, 45 to 70 years. And we had one group that included Collavant and acetaminophen, also known as paracetamol. And we had the control group with just paracetamol. So we included this paracetamol group because it was the standard treatment. It still is the standard treatment in many countries. So we wanted to have it as baseline, but it's already well known that long-term paracetamol treatment doesn't really treat the disease. It just diminishes the symptoms. And we gave them these treatments over the period of 3 months. So, and what were the results? First, we wanted to check mobility, the function, joint function. So here, first we use the WOMAC. That's the, I'm sure you are all familiar with. It's the most validated function test used for osteoarthritis. And what we saw is that function after 3 months of treatment with just acetaminophen didn't significantly change overall. So here in the WOMAC, the questions that are normally asked are day-to-day questions, if how osteoarthritis impacts on their lives. Like, how difficult is it to you to put your socks in the morning, to get in and out of a car, to stand up from the toilet, to walk a block? So and you get to answer from 1 to 4. The higher the number, the worse that your symptoms are. So here a higher number means worse results. So when we measure the difference from final to baseline, there was a non-significant trend towards worsening in this acetaminophen group. Of course, there was no major change seen. Luckily for all of us, osteoarthritis does not develop that fast. But when adding Collavant, we could see a huge improvement in knee function compared to baseline. So we could see that in just 90 days, they really can feel that they can do more things in their daily lives. They can work better, dress themselves better. So it's not very complex things. They're things that you need to do in your life and can be a real burden for them. Of course, we also measured pain because it's one of the main complaints of the osteoarthritis patients. And acetaminophen over 3 months of treatment did not change at all. The pain levels they were the same after the treatment than before. Of course, it had its 6 to 8 hours effect, but after it wore off, it was off. But then in the Collavant group, we saw a 3-point improvement in pain. It was actually cut in half. So it's so great because in a scale from 0 to 10, it's considered that the minimum clinically meaningful difference so that the patients can actually say, I feel better, it's 1.1. So here we got 3, so almost 3 times as much. So it really made an impact in their lives. And of course, cutting your pain in half, it makes a difference. So it's not just numerical, and it was significant versus acetaminophen group. And of course, the symptomatic aspects of osteoarthritis are what your patients will feel and will make them feel better after a while with the treatment. But of course, you also want them to give them their joints as a long life as possible. So they will end up needing surgery, but if we can delay it a bit, the better. So here we did a study where we evaluated osteoarthritis progression, and we had 2 treatments, one glucosamine chondroitin, high quality ones, not food supplement quality. And we also had another group taking glucosamine, chondroitin, and Collavant. And this was a 1-year study, so it was quite a long follow-up. And what we could see is that really collagen degradation biomarkers changed between groups. So here we saw is that collagen type 1 in the glucosamine and chondroitin, so in the glucosamine, chondroitin, and collagen group was significantly better than in the group that only included glucosamine and chondroitin. And CTX2, that's the one most directly related to osteoarthritis because it's the cartilage one. What we could see is that the glucosamine and chondroitin group, it actually had some reduce in collagen degradation in the first 6 months. That's time 1. But then it went up again in the next 6 months. But when adding the Collavant, this reduction was sustained, maintained, and even improved with time. So we were really making a difference in the collagen degradation pattern of these patients. It was very significant, and these markers were reduced over a period of 1 year, continuously and constantly, and even with better results. And of course, does this reduction correlate with anything that you can also actually see or measure, not just a urine test? Yes, what we saw here is that this was hand osteoarthritis. So they were measuring the Kelvin-Lorentz on all the joints in the hands and then adding up these results. So what we saw in the chondroitin and glucosamine group is that here from baseline to 1 year of treatment, there wasn't a steep increase in the Kelvin-Lorentz scoring. But when we looked at the glucosamine and chondroitin group only, this increase was very, very slightly. It was not as big as the one. So therefore, it really decreases disease progression. So not only, and it was of course significant compared to the other group. So really, to wrap up a bit, it's native type 2 collagen and the natural type 2 collagen. It can significantly reduce pain, cartilage degradation, as confirmed in the biomarkers that I just explained, and also with these radiographies, the radiography markers that I just showed you. So it was really, really good results. And it demonstrates that Collavant and 2 could exert cartilage protection for osteoarthritis. Everything through this specific and unique mechanism of action called oral tolerization. So far, it has been proven safe and well tolerated because collagen is a molecule naturally occurring in the body, present in some even foods. If they are meat eaters, it can reduce joint discomfort, inflammation, and improving joint function. That it's actually this discomfort and function is what your patients will feel the most. It also offers a comprehensive cartilage protection. And it has also been clinically proven to reduce collagen degradation and in its biomarkers. And it's available in the main markets, like in Europe and in the US. And it has been for years. So collagen, so cartilage, we know it's a very key structure in joints, but it's not the only one there. So we also center with Kneeflex, we want to center and target all the structures on the joint. We want to take us a deep approach and nurturing the joint as much as possible. So they also went for Mobilee, our product for synovitis. So as you know, synovitis is the inflammation of the synovial membrane that leads to reduced production of hyaluronic acid. It also impacts the lubrication between joints, what leads to increased friction, and more friction means more damage, and more damage means arthritis progression. So we really think it's a key point to maintain this synovial fluid with the appropriate viscosity to allow smooth gliding between the joints, to allow nutrients actually to reach to the cartilage, so that the cartilage degradation that it's inevitable and it occurs, it really has some nutrients to rebuild it. So, and therefore we developed Mobilee. Mobilee is our patented rooster comb extract, and it's naturally rich in hyaluronic acid, polysaccharides, and collagen. Its unique composition has a proven synergistic effect, that it's what actually gave us the patent. It stimulates the endogenous production of hyaluronic acid. It's much more potent than fermentation hyaluronic acid, that it's one of the alternatives up there in the market. We also, one of the big questions with hyaluronic acid, it's a big molecule. Is it absorbed? So yes, we have documented evidence of intestinal absorption of Mobilee, and its efficacy has been proven in multiple clinical trials. So let's go to a bit of the mechanism of action of how Mobilee works. It stimulates the endogenous hyaluronic acid production. So here in this graph, we cultured synoviocytes from patients actually, and we had the baseline conditions of hyaluronic acid generation. Then we added Mobilee, and we saw an increase of 200 times the results obtained compared to baseline. And then we also tested hyaluronic acid from fermentation at the same dose as Mobilee. And as you can see here, the difference is significant. And therefore, we concluded Mobilee was much more potent than fermentation hyaluronic acid. It also helps to reduce the release of prostaglandin E2 that's related to pain and inflammation. So here we had the control cells. We stimulated them with a pro-inflammatory molecule, interleukin-1 beta. And of course, the prostaglandin E2 levels rose. But when we added Mobilee to the cells with interleukin-1 beta, together with interleukin-1 beta, these pro-inflammatory triggers were far lower. So really, it helps to reduce inflammation. And as I was mentioning before, we tested, of course, absorption. We don't want to have a brilliant product on a petri dish that it cannot work on a subject, on a patient. But here we tested that the three main segments of the gut, the duodenum, jejunum, and ileum, and we could see absorption in the three of them. So it's really not only did it absorb somewhere, it's absorbed everywhere. And what allows you to have a better viability of the product. So regarding synovitis and osteoarthritis, I have here a lot of quotes that, of course, synovitis is correlated with faster progression of osteoarthritis. It can be present from an early stage. It can also be a trigger towards osteoarthritis development, but I'm sure you're already well aware of them. So just to summarize and not to read them all out loud to you, synovitis is a very common condition in osteoarthritis and has been associated with increased symptoms and structural progression. So leading towards a worse joint health for your patients. And therefore, if we have something to keep it in line and to treat it, let's go for it. So here you can have a bit of the numbers of the effectivity of Mobilee. Here it's its development code, IB004, compared with hyaluronic acid from extraction and fermentation. So we cultured the cells, and what we saw that Mobilee values were significantly higher than the new synthesis of hyaluronic acid values for hyaluronic acid from fermentation. And as I was mentioning before, having preclinical results is a key point of development, but we want to treat real patients. So here we have a compilation of clinical study results. So regarding synovial effusion, so here we did nutritional intervention studies in healthy subjects with joint discomfort. So these subjects, we gave them 80 milligrams of Mobilee per day versus placebo. And in this, and here regarding synovial effusion, we saw a non-significant improvement in the placebo group, but we had a very significant improvement in the Mobilee group. So of 2.5 millimeters, that's very significant, taking into account that more than 4, it's considered pathological. So really we are not working with very big values here. And also what we measured is that we increased muscle strength. Just with patients that were just taking the product, they were not instructed to do any fitness activities, any sports, any dietary changes, none. And compared to the placebo group that were treated exactly the same, it was a blind study. So really the doctors could not give different directions to one group of patients and the other one. So really, and muscle strength was increased by 17% in just 3 months of taking Mobilee. And therefore, this strength, of course, is a protective factor towards worsening of the conditions. And strengthening your muscles around your joint, it really helps with disease progression. So here in this result, you can see that Mobilee improves muscle function, reduces synovial effusion and pain, thereby slowing the progression of osteoarthritis. Here in the reductions in pain, it were measured again with the VAS scale, one standard, and we could see significant improvements at just 2 months. But really at 3 months, it was again very significant. As we were mentioning before, any improvement past 1/1 is clinically meaningful. As you could see, the placebo had some placebo effect, but it failed to reach any clinically meaningful. But we got like twice the minimum clinically meaningful difference in the Mobilee treated patients. So really they could feel this improvement. Also, not only we wanted to measure this subjective, again, so the subjective feelings of the patients that may or may not be triggered by placebo effect. We also wanted to measure if Mobilee was doing something beyond that. So we did a genomic study, actually we measured real gene expression. And if the slide wants to go further. And we saw several changes in many genes, expressions compared to the placebo and to baseline. And the most relevant ones here are this shown here, that as you can see, they even go in different fashions from Mobilee and placebo groups. And while Mobilee was able to downregulate all the genes that are related to extracellular matrix destruction, and also, of course, disease worsening and progression of the disease, these effects were not seen in the placebo group. So a significant reduction in this peripheral blood gene expression of molecules important to cartilage degradation was found. And in this muscle strength increase, it was, as we were mentioning before, 17% without doing any kind of sports or exercise. So it showed that Mobilee supplementation significantly reduces synovial effusion and pain, reduces expression of osteoarthritis biomarkers, and it can strengthen muscles. So it improves muscle strength, thereby protecting the cartilage. So here, as synovial effusion and pain are so key, we are including some results of other trials where we have seen this really reduction again in pain, in synovial effusion. It was not a single case, a single study findings. They were found in several ones. Oops. So really, this is in osteoarthritis, a study where these changes were also found, not only in healthy subjects, but also in osteoarthritis ones. And it was safe and well tolerated again. So there's another study, where we compared synovial effusion in Mobilee versus paracetamol. Here we also measured synovial effusion at just 1 month. And what we saw is that there was a huge decrease within the first month of treatment in the Mobilee patients, by the 6th month, it was gone. It was not even there anymore. So no patient had synovitis. And then the BASIS score, of course, it was consistently and constantly being reduced compared to paracetamol, not just to placebo. So of course, Mobilee also outperforms paracetamol, as we were seeing before with Collavant. And therefore we may delay osteoarthritis progression, which arcs perfectly with Collavant because they work through different mechanisms of action. They go in different structures of the joint, and it can give you a more comprehensive approach. So as highlights of all this presentation I just gave you, Mobilee is a roster-com extract rich in hyaluronic acid for joint and muscle health. It has a patented, unique, and synergistic composition that contains hyaluronic acid from a natural source. It stimulates synoviocytes, and therefore it enhances endogenous hyaluronic acid synthesis. So really we are pushing them to work better. It's absorbed, that it's a big concern normally with hyaluronic acid. It reduces this joint discomfort, inflammation, synovial effusion, and increases muscle strength. So results that your patients will feel in a short period of time, but they will also feel on the long run because they will be having healthier joints for a longer period of time. It has proven efficacy in multiple clinical trials, including nutrigenomic study. It also widely available in many regions like Europe and the US. And it has been approved by the EFSA as a novel food and also as a GRAS by the United States. So up to here, my presentation. Thank you very much for your attention. I know this is a lot of information, and now I leave the floor to Dr. Harsh.
Thank you, Esther, for a very enlightening presentation on both Collavant and Mobilee. And what I gather from your presentation is usage of both the ingredients. It does bring about a reduction in pain and inflammation, also the synovial effusion in the patients with arthritis. And this put together goes on to check the progression of the disease.
Yeah,
that is the crux of the entire talk that you have given to us. Now, where do you see it being used? Should it be the first treatment, or should it be added on to paracetamol, as we like to call it? You have said that acetaminophen is, you have used the word acetaminophen. How do you see where it finds a place in the therapy? Right at the beginning, when the patients first come and complain of it, or maybe add on later on to maybe paracetamol, dose requires an escalation or something of that sort.
Yeah, I would rather use it like both in newly diagnosed patients that just are coming to us complaining, or on patients that have been maybe taking some other products for a long time, it's not working well, or they have already been on paracetamol and they really need to take them every 8 hours because the effect keeps wearing off. So even if your patient has been diagnosed for a while, why not go for it? So it can also, of course, help protect towards further worsening. Of course, we may reach a point where the joint is dead and we have no other option than surgery. But if we can go earlier, or even if we have a very, very, very bad joint, just to avoid any kind of damage from compensation from the other end of the body, we could also try to use these products. I would say with any, as they're very safe with any patient with any joint complaints, to see if they can help us, because they are safe, they are well tolerated, we are not causing any harm by giving them. So they can be given to both earlier stages patients and also later stages. Or even if you have an athlete that has some joint complaints but not even fully developed osteoarthritis, they could give them a boost and a longer life for their activity.
So what's the longest studies, where's the longest use you have documented with the use of these ingredients? I remember somewhere in your presentation, you had shown me a study where the ingredients have been used for almost a year
Yeah, for 1 year.
or
So
1 year or so. Is there a time frame? Is there a restriction for how long they can be used, or one can continue to be used, and there's no such limitation?
no, there's no limitation. So in this case, it was a patient with osteoarthritis that was progressing quite fastly. But we see like no point in doing actual clinical trials, follow up for 4 or 5 years. It doesn't really make sense. We will lose a lot of patients to follow up. But these products have been in the market for years. There's no limitation. There have been doctors giving them to their patients for as long as they're feeling comfortable with. So really, I see no problem with a long-term treatment with these products. So there's no safety concern of.
Now, since you have been twice, you have mentioned the safety issue. You have said no side effects are also there. So there's no documentation. I'm sure you would have some pharmacovigilance kind of a setup. There would be some documentation. Even though I remember towards your last slide, second last slide, you mentioned that the ingredients have been accorded a status of GRAS, generally recognized as safe by both US FDA and the other regulatory agencies.
Yeah, EFSA is the European Food Safety
Yes.
Assessment.
So, yeah.
So yes.
Is there are there any reports of any side effects, any adverse events with the use of these agents?
No, we've never had any adverse event. Of course, in clinical trials, you get adverse events for everywhere. You get COVID as an adverse event, so it's not really related to the product, but related to the product. We have no reports of adverse events of any kind. And for example, for the EFSA approval of Mobilee, they considered that someone was chronically overdosing on Mobilee for a very long time, and they found no problem with it. And the European food agencies are also very strict with safety, regarding safety in these supplements, and therefore they are perfectly fine to take. And yeah, and I think there's no concern if someone say, okay, I want to take it for 5 years. So go ahead.
Okay, and one last question, because I saw some of your studies are a bit dated, and since they're about half a decade to a decade ago. So how long these ingredients have been in the market? For a decade or slightly more than that, or?
Yeah, a bit more than that, for like about 15 years, both of them. So
So,
yes, so they are very well-known products, were well developed.
Okay.
And also have a very good presence, and you can have this assurance that if a product has been that long in the market, it's not going to harm anyone, because it would have been withdrawn much earlier, or if it wouldn't have worked, we would have stopped manufacturing it, because there would be no sense in manufacturing a product that just works within a clinical trial context.
So thank you, Ester, for such a lovely presentation, and it was a very insightful one. And the take-home for the audience is reduction in pain and inflammation, as well as the effusion, and it helps us to check the disease progression safely without any attendant side effects. That is what we gather from Ester's presentation. Do stay with us, Esther, for the presentation by Dr. Rathod. And maybe there are some questions towards the end of the program, for which we would like to hear from you. With these words, now I invite Dr. Niranjan Rathod to share his thoughts and experience with the combination of Kneeflex. And as I mentioned, ladies and gentlemen, towards the beginning of the program, Dr. Rathod is an renowned orthopedic surgeon from Mumbai, with both graduate and postgraduate qualifications from, say, GS Medical College and the KEM Hospital, Parel, Mumbai. With these words, I invite Dr. Rathod. So over to you, Dr. Rathod.
Yeah, thank you very much, Chairman. I would like to say something about one question that you asked Esther.
Yeah, sure, sir.
How long can you use this molecule? This molecule is very safe. It can be used for as long as you can. And whether this molecule will work on a particular person or not, That thing can be found out by algorithm, like I'll tell you. Grade 1 osteoarthritis, it will work. Grade 2, it works. Grade 3, it may work. Grade 4, it does not work. Now, how to go around whether this patient is in grade 1, 2, 3, or 4? Grade 1, there is only one thing positive about grade 1, that is synovitis not responding to NSAIDs. I wait for 3 weeks, and at the end of 3 weeks, if the synovitis persists, then I consider that case as grade 1 and I start this particular Kneeflex immediately. In grade 2, what happens is there is a subarticular cyst formation and synovitis which is already been present. In such cases, and also you will see tibial osteophytes. So when you see such picture as to inflammation, subarticular cyst, and tibial osteophyte, and may or may not be a reduction in the medial joint space of the knee joint, then this is to be considered as a grade 2. Here also you should start as early as possible. Don't wait for the response of NSAID, because this particular patient has already been to 4 or 5 people and they've already finished their courses of NSAIDs and these that. So here, the earlier you start, the better is the result. Now in grade 3, there is massive destruction. There is decrease in the joint space medially and severe pain, but surprisingly at this stage, inflammation is much less. It is somewhat like a dry knee joint. There is not much of a synovitis, but the pain factor is so bad that patient's gait changes. He's got a varus, and ultimately this knee joint problem settles into the lumbar spine and other areas of the body. So in grade 3, you start early, but the destruction is so bad that to give assurance to the patient that you will definitely improve with this is difficult. However, pain relief will be there, but the progression continues. Now in grade 4, everything is haywire. There is no cartilage left to the knee joint, so there is no question of regeneration of the cartilage. There is no question of further degradation to the cartilage. There is hardly any synovial effusion. So everything is so much haywire that it is very difficult for any molecule to work on grade 4. So grade 4 is directly for patient going to the surgeon for replacement. Now, second thing that you said is how long can you give? I have been giving this particular molecule initially for only 3 months. But now I have realized that my patient, without even asking me, are taking this particular medicine for 3 months to 6 months to 9 months to a year, because they find it very easy to get this molecule, and side effect being not there, they are taking it for a long period. And sometimes they come and ask me also, doctor, is it okay if I take it for a long time? I said, why do you want to take it for a long time? Only thing they say, our pain is gone. So if the pain is a main factor, then this particular molecule works. And sometimes you will not get anybody going from grade 2 to grade 3. And the surgery can be, if at all necessary, can be prolonged for more than 5 to 10 years. 5 to 10 years is quite a good. And so far as economy is concerned, if you consider a knee joint getting surgery done, the amount of money that one spends is 10 times more than one taking the same molecule for a period of 1 year to 1.5 years. So on this ground also, my suggestion to everybody is use this molecule as much as possible. Cost is not the criteria. Anything that you would like to ask me?
Thank you so much, sir, for summing it up and putting it across so succinctly, So as I understand, and it's for the benefit of the audience, that grade 1, yes, 100%.
Yes.
We should be looking at the molecule, and we should be starting with the molecule. Grade 2, it's also beneficial. And then the progression further on, grade 3 and grade 4, oh yes, there's no thought about it. Now, what has been your experience with monotherapy and with a combination therapy, in sense that have you ever felt the need to add on any other drug to the combination? I'm sure in grade 2 patients or grade 3 somewhere, there would have been the other drugs which would have been added to the combination as well.
My suggestion is other combination molecules which are added to this Kneeflex, they help in reduction of inflammation to a great extent.
You are
And the
emphasizing
effect-
on Corculife and
Aflapin.
Aflapin, yes.
And if the inflammation is under control, then destruction of the cartilage is much more delayed. So I have no objection in one taking Kneeflex combination, full combination, including Mobilee and Collavant. They will have a fantastic good result if started early in their disease progression.
Sir, one of the biggest features when we talk about paracetamol, and also as Ester has emphasized their study, there was paracetamol. While using the combination, let's say in the grade 1 or grade 2, did you ever feel a need to add on the paracetamol to it? Or it was just the Kneeflex combination which you were using?
Frankly speaking, paracetamol is of use only in first 3 weeks period.
Okay.
Afterwards, Aflapin and Corculife takes over as an anti-inflammatory agent. And it kills the pain almost 90%. And collagen type 2 will start working after about 4 weeks to 6 weeks period. Between 4 and 6 week period, if you ask the patient, how do you feel? With this combination, they'll say that, Dr. Sahab, thank you very much. You have avoided huge big expense and pain. And most of the knee replacements are not 100% sure. If they develop one complication, then the only alternative remains for them is to go for arthrodesis, which is, it's very bad, worse than a surgery. So this particular molecule, you should have patience to take it for at least, my opinion is, you start seeing the effect at the end of 6 weeks, full-fledged. And by 12 weeks period, person is almost happy. Chalo, God, you are my God. You got my point. So, and those patients who definitely suffer little more than 3 months, their daily activity is such that their, wear and tear is extremely high. They are sort of a sportsman type or heavy worker type, or those who are in Indian style, those who squat down on the floor. And these are the people who tend to have a little more stress on the articular cartilage. So they have to take it for a little longer period. And I have no objection in telling them you can take it for as long as you can.
One last point, though she has been emphatic and you have been very confident, but I still want to drive one last point home on the safety, because I'm sure you would have used it now in n number of patients in your practice. Has anyone ever complained of a side effect?
In my opinion, nobody has suffered. Nobody has even asked for some medicine for this and that. In the initial period, some people do complain of flatulence.
Complain of, sir?
Flatulence means gas.
Flatulence. Yeah, flatulence. Yeah.
But then over a period of time, within 2 weeks' time, that complaint goes off. So apart from that, I have not seen any other side effects.
So the efficacy and the safety are hallmark, and the take-home message is we start as early as
possible.
with the use of the combination.
I will replace, make the whole thing very clear.
Yes, sir.
Once the pain starts and you see the patient, wait for 3 weeks with NSAIDs, because it could be any other synovitis. If at the end of 3 weeks your NSAID is not working, that's first grade 1, and you should start immediately.
That's the take-home message, sir,
Yes.
that we have got here. If the audience has any questions, they can write it at the chat box. I do not see anything. I think we have put it across very, very succinctly, both Ester and Dr. Rathod. It's a lovely experience listening to you. And that with these words, I thank you. I'm looking again at the chat box. We do not have any questions coming. So I hope the message is very clear. People have understood. Our audience have understood.
Can I ask one question to Esther?
Yes, sir. Yes, you can certainly, sir. You can ask. Esther is still with us for 3 minutes.
Yeah.
Esther, is there any chance of getting collagen polypeptide molecule by vegetarian source? Means since you are in a research modality, because in my
Not
area,
really. Because collagen is an exclusively animal origin molecule. So all these kind of vegan collagens that there are out there in the market are normally amino acids from plants or from yeast, but these are for hydrolyzed collagen that try to mimic the composition. But getting a vegetarian or a vegetable origin collagen, it doesn't really exist on the.
You think there is any possibility of getting it in future?
Well, who knows what's possible of getting into the future. We may even get totally rid of osteoarthritis, and that'll be great. It's very difficult but I find it difficult. It's not impossible, it's nothing, but I don't see it in a 5 to 10 years time that we will have this vegetable alternative to collagen, because vegetables don't have collagen. So really you cannot extract it from any vegetable.
Okay.
Anything else? Anything, Esther, you would like to ask Dr. Rathod?
Well, I was very pleased to know your experience. It's great because we are working more in the lab and more in another environment. So knowing your real life experience has been wonderful. And I really like that your patients felt that way. If we try to get your contact, if we get more questions in the future regarding specific applications, I'll let you know, because I think that your experience is wonderful and you have far more clinical experience, also knowledge about our molecules than we do.
We are a big country, Astro. Doctors have gets lot of patients, and we love our food. So obesity goes with the population. That's how it is.
Well, you have delicious food. You have the right to love your food.
Yes. So that's how it is. With these words, I thank you, Dr. Rathod, for very clearly putting the combination, the Kneeflex, giving it place in therapy, which is very important for the audience to use it, where to use it, and how to use it. And equally thankful to Ester for emphasizing and re-emphasizing on the progression arresting abilities of the ingredients. And of course, yes, pain remains the most important aspect and hugely determines our quality of life. Thank you so much, Ester and Dr. Rathod, for enlightening us on Kneeflex today. With these words, I'm signing it off. Thank you so very much. So over to the
Thank you very much for inviting us.
Thank you.
Thanks.
Thank you very much.